So imagine there's an injection that you can do once a week. It will help you lose body fat. Do you want to know what it is? Keep watching and we'll let you know. Hello, so we're back with Dr. Rudy Eberwein from the Medical Health Institute. So happy to have him back to discuss a very hot topic, semaglutide, if you didn't guess. That's the name of this once-a-week injection. But there's also tirzepatide, which is on its way both to the UK and I believe the USA. So Dr. Eberwein, happy to have you here to discuss this topic about fat loss, because we don't necessarily say weight loss, though it does reduce your weight through reducing your body fat and may have some other benefits. So glad to have you here, and let's talk about first semaglutide, which has been in the news quite often and lately, and the new improvements coming soon. So semaglutide, what is it, and how does it actually help people lose body fat?
Yeah, so glad. I love talking about this because I've never been as excited about a medication as that class of medication. So semaglutide and the newer version, tirzepatide, they're called GLP-1 receptor agonists, glucagon-like peptide 1 medications. They were first FDA approved in the US in 2005. So this is not a new class of medications. And their indication was mostly for diabetes. Okay. Really good treatment for diabetes because what it does, it targets a hormone called the incretin hormones, part of the gut hormones. What they do, they increase when you take oral glucose sugar, it increases your own production of insulin. So it makes your body get rid of the sugar quicker, right? Okay. So it increases your own insulin. So that's how they started back in 2005. I've been using that class of medication since 2005 for diabetes because something people don't realize, using insulin for diabetes is the wrong thing to do. If you have type 1 diabetes, yes, you don't have a choice. You have to use insulin. Right. If you have type 2 diabetes is mostly a lifestyle disease. Yeah. But you have too much fat, visceral adipose tissue, bad lifestyle habits, possibly a family history, and you develop insulin resistance and eventually type 2 diabetes. So the key is to try to not make you need insulin. There was a recent study that shows that patients who are on insulin, diabetic patients who are on insulin, yes, their hemoglobin A1C go down, but their risk of cardiovascular disease and heart attacks go up. Because insulin is a fat, it increases fat formation. Yeah. So yes, we may decrease the blood sugar, but the long-term effects are not good. So type 2 diabetes, the goal is for you not to need insulin. And the way we do this, better diet, improving insulin resistance. So I've been using the GLP-1 since 2005. Every 3 to 5 years, a new generation would come out. Got a little better. 2014, the first GLP-1 was FDA approved for weight loss in the US. It was called Saxenda. That's the brand name. I think it was liraglutide. Okay. All of them were finished by Tide. This, yeah. So those are Tide medication. I've used Saxenda for some time. Wasn't great for weight loss. Then in 2017, that's when semaglutide came out. So it was first for diabetes. Ozempic is the brand name. Right. And doing amazing for diabetes. A1C, that hemoglobin A1C, the average blood sugar over 3 months, would finally get from 10 or 11 below 7, below 6. And those patients were losing weight. They lost so much weight that the company applied for FDA approval without needing to have diabetes. So semaglutide, under the brand name Wegovy, became FDA approved to use for weight loss even without diabetes. So again, the advantage of those GLP-1 medication is that it improves insulin resistance, which is at the basis of most of our chronic diseases. It also decreases your digestion rate, so you're less hungry, and you tend to lose a lot of weight and body fat. Yeah. So semaglutide does cause body fat decrease also, just because you tend to eat less. Right. Right. So you lose weight, you lose body fat, you lose also some muscle mass, and we'll talk about this because there's a lot of criticism whether those GLP-1s cause too much muscle loss. Yes, so we'll go over that. But let me finish with the progression of GLP-1s. That's amazing. So as we've seen the newer generation of GLP-1s, we're like, wow, this helps for weight loss. So now Wegovy got the FDA approval. In the US, we use it a lot. Patients are getting amazing results. The results are so great that it became a cultural meme. At the Oscars last year, they made jokes about it. The presenter was like, I see everybody in here smaller. Are they all using Ozempic? Because it works. Millions of people use it. Even the people who cannot get it through their insurance, they are paying $1,500 plus to use it because we've never had a medication that is so effective for weight loss. So semaglutide, the studies are showing that usually I think they did a study of about a year and I think 4 months. And majority of patients were able to lose about 10 to 15% of their body weight and help maintain it. Their blood sugar improved, their cholesterol improved. So what's amazing with this, it's not just that you lose weight, you also improve your cardiometabolic parameters. So much so that cardiologists like to prescribe this because it helps decrease fat. You know, I like to talk about that, visceral adipose tissue. When you have a lower belly fat, you'll do follow-up labs like your HSCRP, inflammatory markers.
Right.
You'll see a decrease. You'll follow up the cholesterol. You'll see a decrease. So not only are you losing weight, you're also improving your cardiometabolic parameters. And that translates into lower risk of heart disease, heart attack, and stroke. Whereas if you use insulin, your blood sugar will go down, but you do not improve your cardiometabolic parameters.
Or your body fat.
So that, your body fat, you'll get more body fat, more inflammation. So I've used a lot of semaglutide. I love semaglutide. And I know now they're using it in the UK. I think they call it the skinny jab.
Skinny jab, yeah.
Yes,
it's Ozempic. I've got some at the Whole Men's Pharmacy, yeah.
Yeah, Ozempic is semaglutide. Again, a lot of people don't understand. Semaglutide is the generic name. That's the name of the medication. The brand names, you have Ozempic and Wegovy. They're exactly the same.
Yeah, your lovely pharmaceutical companies in the US love to differentiate the two based on different indications.
Yes, it's indication and dosage, but it's the exact same formulation.
So what would be the optimal dosage, just out of curiosity, for weight loss if you were to use Ozempic, for instance?
So
label.
Wegovy goes up to 2.4 milligrams
so it's a higher
once
dose.
a week. It's a higher dose.
Okay.
But the reality is, in my clinical practice, most of my patients don't go up to those doses. You have to start at the lower dose, 0.25 milligram or 0.5 milligram.
Okay.
Usually it's 0.25 milligram once a week for 4 weeks, then 0.5 milligram for 4 weeks, then 1 milligram, then 1.5. And just like everything that we use, it's never just the medication. If you just give the medication, they're so powerful, those GLP-1 medication, that most patients will still be successful. But if you give it with the right nutrition support, the right amount of exercise that the patient has to do, the right mindset support, that's when you see even better results. So for me, I don't always push the dosage at the highest. It all depends on the patient. If it controls your appetite enough, if you feel well enough, we see what's your sweet spot. I'm always trying to find what's the lowest effective dose of a medication. What's the lowest dose that I can use that minimize side effects and maximize your results. So to answer your question, semaglutide can go up to 2.4 milligram. Do we need to go there for all patients? I don't think so. It's a good tool. You could go up there. The thing with semaglutide, because it slows down digestion, this is how GLP-1 medications decrease appetite. There tend to be quite a few side effects, especially the gastrointestinal side effects. So patients can complain of nausea, acid reflux, constipation, sometimes diarrhea. And most patients will tell you, they can't even smell food. The side effects are there. Not everybody gets it. And then that's when we have now the new GLP-1 agonist, tirzepatide. Tirzepatide to me is an improvement from semaglutide. So tirzepatide, they've actually done studies where they compared head-to-head semaglutide versus tirzepatide.
Right.
And they saw that patients on tirzepatide were able to lose more weight and had fewer side effects.
Now, you said there were two mechanisms of action for tirzepatide compared to semaglutide.
And this is what's been the most amazing development. So from 2005, when they developed those GLP-1 medications, up until semaglutide, they were all GLP-1 agonists. They only targeted that one hormone, GLP-1, which is an amazing hormone for all the benefits. Tirzepatide has been the only one that was able to target two different incretin hormones, GLP-1 and GIP. GIP is glucose insulinotropic dependent peptide, and it is another part of the incretin hormones, kind of does the same thing as GLP-1, but the synergy of those two, I think that's what makes tirzepatide different than semaglutide, Saxenda, and all the previous older generation GLP-1. And what's important to know about GIP is that GIP is the only incretin so far that we found on fat cells. So whereas with semaglutide, you lose body fat because you lose overall weight. Tirzepatide actually induces lipolysis, destruction of fat cells. So that's why, to me, and the studies are showing that tirzepatide is superior than semaglutide because there's actually receptors of that GIP hormone on fat cells.
Oh, that's
So
amazing.
you lose a lot more fat with tirzepatide, the weight loss is more, and you tend to have fewer side effects.
But
So
But then one of the critics who critiques of, then you'll get even more of the death face. That was one of the critiques of semaglutide. People lose so much weight, they got a very gaunt look.
yes.
But we know, and I think we talked about this before, that if you have any weight loss and you lose too much weight,
Yeah.
it's going to show in your face. I mean, is that what your experience has been?
Yeah, so that's what they call Ozempic face.
Ozempic
because
face,
Ozempic came out first, and really, some people, they've been so successful for the weight loss, they lose 40, 60 pounds. Of course, you can lose too much. And a lot of times, especially for older people who have laxity of skin already, and you tend to lose a lot here, you have the gaunt face. There's different ways to look at it. First, if you got Ozempic face, it's because you lost a lot of weight. So congrats.
Yeah, congrats.
If you get Ozempic face, you lost 40, 60 pounds. Congrats. Do something with your face. Get Botox, get something with it. Second is, there's a lot of controversy about who should take Ozempic. Who's the ideal candidate?
Right.
If you just need to lose 15, 20 pounds, that's not what it's really indicated for. But can you tell somebody who started a weight, and I see a lot of women in my practice. I had a patient the other day. She was at 125 pounds all her life. She went through menopause. She gained 20 pounds. She went to 145, and she wanted to lose those 20 pounds. Now, if you look at the FDA indication, 20 pounds, her BMI wasn't that high. That's not what it's indicated for. But that woman, post-menopause, developed more visceral adipose tissue, more fat, and she gained 20 pounds for her usual weight. Can I tell that patient she's not a candidate for it? Yeah, you can say by FDA approval because we need to ration it. Maybe you can have an argument. But she deserves to be able to get the right treatment to get it back into a healthier weight and decrease her belly fat. So there's a lot of argument. Who needs to be on this?
You think with such an obesity epidemic, especially in the United States, everyone should be on it here, at least. And there wouldn't be a ration other than you can't make it fast enough.
That's the main thing. Is the big question in the US is it's so popular that everybody's using it, and diabetics who really need it cannot get it. So I get this, and I always say, yes, if you're diabetic, you need semaglutide or tirzepatide. And if you cannot get it, my heart goes out to you. What's great in the US is that so far we can use compounding pharmacies of semaglutide or tirzepatide, so we don't take it away from the diabetics.
And you can meet the demand and do it in an ethical way.
Exactly.
So the other, I guess, we'll talk about is the linkage or the concurrent use of TRT, testosterone or other HRT, with semaglutide or tirzepatide.
That is my favorite treatment.
Yeah.
So testosterone plus one of the Tide medications, semaglutide or tirzepatide, Tide, plus testosterone, I like to call it the T-square stack. Testosterone and a Tide medication. Because hyperinsulinemia, increased visceral adipose tissue, more fat, more belly fat, has a really strong association with abnormal testosterone levels, and it makes sense. The more belly fat, the lower your testosterone. The higher your insulin, the more metabolic syndrome, prediabetes, strong association with testosterone. So when you give semaglutide, you fix the insulin resistance, but if you also address the need of the hypoandrogenism state, and you combine testosterone for muscle retention, muscle formation, and tirzepatide or semaglutide for weight loss and fat loss, you get the best results possible. So give me a guy who comes to me 20, 30, 40 pounds overweight with belly fat, with a low level of testosterone. I put them on a semaglutide or tirzepatide plus testosterone. When indicated, within 4 to 6 months, this man is a completely different man. Their A1C will go down. Their VAT will go down. They gain muscle mass. One thing I want to explain a lot, people don't understand the importance of muscle. As we get older, we experience sarcopenia, decrease in muscle mass. One of the most important determinants of how we age and early death as we get older is grip strength, muscular strength. So me and you, look at us, we got muscles still. We need to maintain that. This is the way that we can age more gracefully and decrease the risk of cardiovascular disease and death.
So again, one of the other critiques was that these tides can, or at least the semaglutide, can decrease muscle mass. Is that something that you found? And if you're on TRT, that's probably not to worry, or is it a worry?
Yeah, so definitely those medications are so powerful that when you lose a lot of weight, you will lose muscle mass. And they've done studies to compare the amount of muscle loss when you use a GLP-1 agonist versus the amount of muscle loss you have with a regular weight loss program. And they were about the same.
Okay.
The problem with those GLP-1s is that you lose so much weight that, yeah, you can lose muscle mass and more, because if you lose 60 pounds of weight, you lose a lot of fat and you lose
A
some
lot
muscle.
of muscle.
So what we do is you cannot just take those medications in a silo by yourself. You need to find the right diet. You need to find the right nutritionist to make sure you get enough protein. You maximize your protein. So all of my patients, when I see them, when they're doing this diet with one of the Tide medications, I make sure that they optimize their protein intake. You know, you've been in bodybuilding. You
You
need at
do
least a
more
gram.
frequent meals? Or?
Yeah. Well, it depends.
Yeah.
The problem is, because you use those medications,
You're not gonna
sometimes
be
you're not
hungry.
hungry enough. So you can't keep up with your demand of protein.
Right.
So you need about 1 pound of protein per pound of weight. So an average man that weighs 200 pounds needs a good amount of protein.
Okay.
Right? How do you keep up with this? That's when I make sure I tell my patients to supplement maybe with protein powder, amino acids, to make sure that they maintain this.
Probably goes on a bit easier to swallow,
Yeah,
drink
to
something
swallow, to
than
drink
to
also.
actually
Number
sit and
two
eat.
is everybody who's taking those medications, that's when the importance of resistance training becomes even more. You know, I coach my patients on this. You need to do your part. The medication is a very powerful tool, but you need to do your part. This is where, again, me and you, we always exercise.
Yes.
You're here at the conference, but you find yourself at the gym.
Yeah.
I have a very busy schedule.
Or
but
even
I
doing
find
press-ups in the other room.
press-ups in your room. You need to do resistance
Yeah.
training, and people tend to focus more on cardio. Cardio is important for cardiovascular training. We need resistance training.
Yeah.
So my patients who do this, I make sure that they do some kind of resistance training. So, and you need to check for androgen status. If you have low testosterone or low levels of testosterone,
For male or female.
Male or female. Females are being completely hoodwinkled.
Right.
They're not given testosterone. So women also need testosterone. So for male or females, you need to look at the numbers. The way you prevent muscle loss is that you take the right amount of protein, you do resistance
Creatine
training.
as well?
Yeah, creatine is really good also.
Okay.
So that's a really good thing. And you correct the low androgen status, low testosterone status if it's there.
Excellent.
So, and with this, you will get amazing results.
But I guess a big question, or the elephant in the room, is how long can you be on this medication?
Yeah.
Is it a lifelong treatment like
that's
TRT?
a great question. There's a doctor in the US that's associated with the government and came out and said that obesity is a genetic disease, and that if you go on those medications, you stay on them forever. I don't agree with this.
Okay.
Because yes, genetic disease, very few people have a genetic condition that causes obesity, like Prader-Willi syndrome.
Yeah.
So very small, 1 or 2%. But now, can you have it that your parents had it and that you have a higher propensity of gaining weight? We see that, there's no question. But there is also no question that with the right diet, the right exercise, keeping your muscle mass, is that you can stay away from obesity. So the way I use it in my clinical practice, when it comes for obesity or for weight loss, I coach my patient into the right exercise, the right nutrition, the right protein intake. 4 months, 6 months, a year, whatever time they need, they lose their weight. With our coaching, they maintain their muscle mass. And at some point, I want to take them off the medication because I want the patient to use their own willpower, because they gain their weight not because they have a genetic condition. It's because of the bad lifestyle. They could not stop themselves from eating. And I'm not here blaming the patient. I'm not here fat shaming. It's really difficult to change your habits in eating. Most patients who come to my weight loss clinic, they'll tell me they know what they should be doing. They know they shouldn't have that extra donut. They know they should eat more protein, more vegetables, keep their calorie counts. But it's almost a food addiction type of problem.
Yeah.
They know what to do, they can't do it. But now with the power of those medications, they find enough willpower that helps them. When they start getting results, they start getting more motivated and more empowered to keep doing the right thing. But we've seen that patients who used to be heavy lose weight, and then now with their good habits, they're able to keep it off. So a lot of my patients can keep it off. But at the same time, I tell them, be vigilant. Because when you lose weight, the normal reaction of the body is to slow down your metabolism, and you can regain the weight. Even post-gastric bypass, we've seen patients regain the weight. So what I tell my patients, it's once you get to a certain weight, if you come off of it, you try to keep your good habits, make the right decision, eat better, keep your exercise. But if you start gaining weight again, if you gain the first 10 pounds, 15 pounds, come back. Go back on the medication if it's needed.
Would you taper it? Is that an option? Is that in the literature to taper?
There's none really, because those medications, the way they study them is to be on them long term.
Right.
Diabetics most likely need to be on them long term.
Long term, of course.
But if it's for obesity, in my view, I don't think you need it long term. What are your chances of regaining weight? They're there. Just like if you do a gastric bypass surgery, you may regain the weight. But I need to give the patient the empowerment of maybe being able to, with their good habits, being able to stay off the medication. Okay. And if you need to go back on it without feeling shame. A lot of my patients would come back if they gain weight. They're like, oh, doc, I failed you. I'm regaining the weight. I'm like, no, you didn't fail. It's a tough thing to keep your weight off. Food tastes good. You know, like I always say that most people regain weight for two things. Either they're having too much fun or they're having too much stress. A lot of people are emotional eaters, stress eaters.
Sure.
So they were keeping their weight off, and then something's not going right at work, at home, and then that becomes their crutch. They start eating. They start their bad eating patterns again. They start regaining. At this time, I tell them, come back and see me. If you need the help of the medication, I have no problems with it. We need to do anything we can, give you the right tools to help you be successful without the shame.
Absolutely. So going back to not shaming, no T-shaming.
No T-shaming.
And no semaglutide
shaming.
So that's great.
Exactly.
So anyway, if anyone else has tried semaglutide or tirzepatide, let us know in the comments. And I guess at the end of this day, there is no free lunch, but with the right balance in diet, exercise, nutrition, and with the help of semaglutide, testosterone, or other agents, you can get to your goals and to a healthy lifestyle. So thanks, Dr. Rudy, for being on.
If I may add something.
One more thing,
And I told you we are doing this because what's happening a lot is people are getting those medications from their doctors and no support whatsoever. So I've developed a website. I call it the Tide Diet. Semaglutide, tirzepatide, the Tide Diet, where we can really, the patients can go on there, go online, and it's available globally. It's a website, and we'll put the website there.
We'll put the link on there.
Where we really teach people first on what you can do to minimize side effects, what type of food you should be eating. That's very important because what we noticed is what you eat makes a difference on the side effects that you can have. What kind of diet you should be eating. Then there's a section on exercise. We even have a section on self-love. Because while you go doing through your weight loss journey, I always tell people this. I don't want you to say that when I lose 20 pounds, I will be good. I tell all my patients, love yourself right now. I don't care how much weight you got. You're an amazing person. You're a beautiful person. Love yourself now. When you lose the weight, you're still that same amazing person who just lost 30 pounds. But love yourself from day one. So the Tide Diet, we talk a lot about nutrition, exercise, self-love, and we give support for those amazing medication to get you to your goal.
Oh, that's very helpful. And we will put in the link. And when Balance for Hormones rolls out semaglutide, we will have a link in there as well.
Thank you.
So thank you.
And tirzepatide, I've seen that it's starting to be talked about in the UK.
Yeah, I'm looking forward to tirzepatide as well. So watch the space. We'll have it as well. So thank you again, Dr. Rudy.
You're welcome.
And for everyone watching, don't forget to like and subscribe and let us know in the comments what your experiences have been or what your thoughts are about these very powerful fat loss medications. So till next time, thank you.